Welcome everyone, and thank you for joining us for our final session of the Leveraging Midwifery-Led Care to Address Disparities in Equity in Medicaid virtual learning series. I'm Jennifer Moore, the founding executive director at the Institute for Medicaid Innovation. Before we begin today's session, we'd like to thank our funder, the Yellow Chair Foundation, for their commitment to advancing important maternal health topics, especially in the Medicaid population. Through their generous and ongoing support, we are able to offer this free virtual learning series. Jumping into today's session, our presenters will provide information relevant to three main learning objectives that build upon the required activities that you completed before this session. They include identifying action steps for our Medicaid stakeholders to advance the midwifery-led model of care in Medicaid, how they intersect, and how they build upon each other to create momentum, and learning about how one state, in this case, New Mexico, has successfully convened multiple stakeholders to advance midwifery-led care in the Medicaid population, including state Medicaid representatives, Medicaid health plans, clinicians, and consumer advocacy groups. Before we get started with the panel discussion, my colleague, Lydia Tonkino, will review a few housekeeping items.
Good afternoon and welcome to session number 8. I'm going to review some details for today's session along with a few reminders. First, today's session will be recorded and archived on the IMI and CHCS website. Except for panelists, all lines will automatically be placed on mute. During the meeting, the chat feature will be disabled for all participants. We have reserved time at the end of the panel for you to ask questions of our guest panelists. To participate in the discussion with the speakers, please use the Q&A feature to submit questions and comments. Please submit questions throughout the session. The questions will be consolidated and shared by the moderator during the Q&A portion of the panel. At the completion of each session, you will receive an email message with a link to complete a short 5-minute evaluation survey. As a reminder, completion of the evaluation is mandatory as part of your participation in the learning series. We actively review and incorporate your feedback into our future sessions. We look forward to hearing your thoughts in today's evaluation. Finally, all materials will be made available to you on the IMI and CHCS websites about 2 weeks after the presentation date. Dr. Moore, I hand it back to you.
Thank you, Lydia. Before we get started today, we wanted to provide an overview of 2 new resources that we've created, serving as a roadmap to support your efforts. Advancing high-value, evidence-based perinatal models of care require each Medicaid stakeholder to conduct a self-assessment to identify their individual role before they can establish an action plan to support the collective effort. Today's session is focused on taking action. This infographic serves as an environmental scan to highlight the different types of stakeholders who are essential. We have identified the key Medicaid stakeholders, including state Medicaid agencies, Medicaid health plans, the federal government, community members, midwives, and physicians. For each stakeholder, there is a need to look broadly outside of their individual space to identify opportunities and challenges to elevate the identified facilitators and mitigate barriers to achieve success. To accompany the infographic, we have also created an interactive checklist. For each of the Medicaid stakeholders featured in the infographic, we have developed a comprehensive list of actions that can be taken to support midwifery-led models of care and achieve birth equity. This work is a journey. As such, each stakeholder can mark an activity as being either in place, actively planning, or is a future priority, recognizing that this work can take place over a period of time. To highlight the information found in this new action-oriented and comprehensive resource, I will review the checklist for 4 of the key Medicaid stakeholders, including community members, state Medicaid agencies, Medicaid health plans, and midwifery practices. For community members, one potential activity, as noted at the top, would be to participate in and lead community activities such as raising awareness by hosting or attending a watch party for maternal health-related film screenings or local events. Another activity would be to engage hospital and birth center leadership in discussions with community members to make sure local needs are being met and community voices are contributing to decision-making around birth equity. Another potential activity would be to seek opportunities to amplify the voice of the community by joining healthcare organization boards as a community representative. There are multiple opportunities for state Medicaid agencies to support birth equity, including establishing standards for equitable compensation of midwifery-led models of care, or following Medicare guidelines for APRN reimbursement at 100% of the state Medicaid rate. Other actions that state Medicaid agencies can take would be to eliminate incident to billing and evaluating network adequacy to ensure that all midwives are included. States can also take action to ensure Medicaid enrollees have access and coverage to a comprehensive suite of services to complement midwifery-led care, including doulas, perinatal community health workers, and other home visiting programs. Where can Medicaid health plans make a difference in supporting birth equity? To start, health plans can include midwives in freestanding birth centers in the provider directory as a first step. Ensuring that the online platform makes these options easy to find and readily accessible to enrollees would be the next step. Establishing equitable reimbursement for midwifery care and supporting services at a minimum of the Medicaid fee schedule would support the financial sustainability of this high-value, evidence-based model. Another opportunity for Medicaid health plans would be to engage communities and members to learn about their preferences, values, and beliefs, and using that information to align with midwifery-led care as an option. The last Medicaid stakeholder that I want to elevate is that of the midwifery practice. There are opportunities to consider how to coordinate with social services and supports, specifically for the Medicaid population. Midwifery practices can take action by applying a birth equity lens to advocate for the needs of those who are served by speaking with policymakers and the public, while also engaging the community to amplify their preferences, values, and beliefs. Of course, we recognize that not one single action or one single Medicaid stakeholder will, as they say, move the cheese, but the collective actions of everyone can certainly create a movement. This resource is intended to help Medicaid stakeholders to take the first step, or for those already leading efforts to take the next step. And finally, we want to express our gratitude and thanks to those who are listed on the slide who served as external reviewers for the infographic and checklist. Their expertise and guidance was essential. The infographic and checklist was part of your required pre-session activities and can be found on the IMI website. As part of our panel discussion today, we will hear from several individuals representing different Medicaid stakeholders who have been implementing the concepts that are outlined in the checklist. And with that, I would like to hand it to my colleague, Karen Shea, who will be serving as the moderator for today's session.
Thank you so much, Jennifer. I'm pleased to introduce our panelists for today's discussion, which is focused on one state's journey, bringing together multiple stakeholders to advance midwifery-led care in Medicaid. And to that end, we're delighted to welcome advocacy leaders from the state of New Mexico, and will highlight their outstanding work to advance midwifery-led care. Our first panelist is Representative Michaela Lara Cadena. She is a Chicana New Mexican raising two humans in a tiny town while doing her best to show up for the people she loves in open and honest ways. Michaela is the policy director at the National Network of Abortion Funds, working collaboratively to build power and expand abortion access. For many years, Michaela was the research director at Bold Futures, a reproductive justice organization that leads policy change, place-based community organizing, and culture shift by and for women and people of color in New Mexico. Previously, Michaela worked at the New Mexico Corrections Department as the bureau chief of recidivism reduction. Michaela also serves as the state representative in New Hampshire's House District 33 and is a member of the state's Morbidity and Mortality Review Committee. Our next panelist is Denisia Kadena. Denisia is a queer Chicana born and raised in the Mesilla Valley of New Mexico. Denisia is the policy director of Bold Futures, which was formerly known as Young Women United, an organization that leads policy change, research, place-based community organizing, and culture shift by and for women and people of color in New Mexico. Denisia leads the design and implementation of Bold Future's change-making strategies and has deep experience working on issues of reproductive justice, racial justice, and queer liberation. As the lead legislative strategist and policy lobbyist for Bold Futures, Denisia regularly provides policy expertise at legislative briefings, co-authors legislation, guides administrative change-making strategy, and works closely with legislators, partners in state government, and other advocates. In the realm of midwifery, Denisia led successful legislative efforts to establish licensure for birth centers and legislation to allow licensed midwives to obtain and dispense a limited formulary. Denisia then collaborated with birth justice leaders at Breath of My Heart Birthplace and state agencies to develop administrative rules related to the legislation to make the work a reality. And we also have Jessica Freschette Goodfriend. Jessica identifies as a white, non-binary, trans person born and raised in Cincinnati, Ohio. Their work life has emerged at the intersections of social justice, healing work, and anti-racism practice. Midwifery brought them to rural New Mexico and has kept them here for much longer than initially expected. Jessica lives in the Tiwa and Tenwa County and has been influenced and mentored immeasurably by the communities of northern New Mexico that have taken Jessica in and offered them a place to learn, collaborate, grow, and become so much the person they are today. Jessica has been a licensed midwife for 12 years and accompanied hundreds of families in the process of giving birth. Their work has extended into the development of a community birthplace, policy work to transform the conditions of rural healthcare access, building a birth justice movement, and training birth workers from New Mexican communities, among other things. In recent times, Jessica has stepped back from full-time practice to provide administrative support to Breath of My Heart Birthplace and worked on the structural barriers to effective community birth models that seek to serve low-income communities of color and other populations deprioritized by current health systems. Welcome, panelists. Our discussion will run about 20 minutes, followed by a 10-minute Q&A session. So we invite all of the attendees for today's session to please submit your questions using the Q&A feature. Our first question is for Denisia. Denisia, New Mexico's birthing people, families, and persons of color have been served for 20 years by the reproductive justice advocacy efforts of Bold Futures. The organization has been active in policy development, research, place-based organizing, and bringing about necessary culture shifts. Could you tell us about the organization, how it was started, how it's funded and sustained, perhaps your role as the policy director, and give us some examples of how the organization operates to influence advancements in midwifery-led care?
Great. Good afternoon or morning, depending where all of you are. Hello, my name is Denisia Kadena. As stated, I'm the policy director of Bold Futures. Yes, Bold Futures is celebrating over 2 decades of work in the state of New Mexico at the intersections of policy, culture shift research, and place-based organizing. For us, our entry into midwifery work really came from the experience of our staff, our leaders, and our overall communities. To put it quite frankly, many of our staff and community members and leaders started becoming pregnant and giving birth with midwives. And really looking at that landscape and seeing that it was not accessible to our family prompted our work in policy and other areas of work in midwifery. For what that has looked like for Bold Futures, we really have created an environment in New Mexico where midwives and doulas and associated birth workers can hopefully remain and stay catching babies and assisting families, where we can really provide some technical assistance and support in policy. So I'm sure we'll get into it more, but we've worked closely with Breath My Heart Birthplace, for example, to pass legislative policy to create the licensure of birth centers, to pass legislative policy to allow licensed midwives to carry a limited formulary of drugs. And both of those policies were critical to advancing the state of New Mexico forward.
Mhm. Thank you, Denisia. So much good work happening with Bold Futures in New Mexico. And yes, we will get into a few more details later on. Jessica, the next question's for you. As a practicing midwife and executive director of the Breath of My Heart Birth Center, could you give us some background on your role, the population you serve, the birth center's operations, how you find time for advocacy work, and plans for business development and growth?
Yeah. So as said before, my name is Jessica Freschette, good friend. I have been involved since the beginning of the community project that's now known as Breath of My Heart Birthplace. We convened stakeholders in 2011 and essentially had 2 years of community-based strategic planning before we ever launched a clinical program. So that background is really important, I think, in the context of this conversation, because our work is very significantly guided, not only based on what the populations of the Espanola Valley, which is a mixed tribal community and encompasses 6 of the Tewa-speaking pueblos, which are located in northern New Mexico, as well as Chicano communities that are both rural and within the boundaries of the town of Espanola. That stakeholder work on a community level has been incredibly important in terms of guiding the trajectory and the priorities of the project. We have developed quite a bit since then, and we now are a licensed birth center. We knew when we set out that there were specific barriers to becoming a birth center around Medicaid reimbursements that we would have to address if we wanted to have a sustainable practice in the community where we operate. Certainly our participation in the policy landscape has been a combination of necessity, because ultimately the populations that we serve are not able to access quality healthcare for a range of reasons, and Medicaid reimbursement and the scope of Medicaid services being a significant one. And then also because there was opportunity within partnership with Bold Futures to be able to work with a partner that understood our community stakeholders so well,
Yes.
and was able to work in a grassroots way with us in the policy field really made everything possible.
Thank you so much, Jessica. Such great work going on at your birth center. And our last question in this sort of setting the stage realm is for Representative Cadena. You serve as a New Mexico State Representative for District 33. Could you describe New Mexico's environment for health equity and birth outcomes, and how advocates like Bold Futures and Breath of My Heart Birth Center and state government have supported midwifery-led care for the Medicaid population?
Thank you, and so much to all of you all today for being in this conversation with us here at home in New Mexico. I am honored to serve in New Mexico's House District 33. And like so many of our families, I come from a rural community. When I take these small town values to our state capital, it's important to me that we talk about the way all of us have opportunity to access the healthcare we need, and far too often in an under-resourced state like ours, talk about how too many families don't have networks of care that serve their unique needs and their vulnerabilities. I'm one of those New Mexicans that was able to have the care of licensed midwives through my pregnancies. And frankly, that changed my life. It changed my graduate research, and it's made me committed to expanding models like this for the communities that most need them. When we look at midwifery across the country and these kinds of models of care, I'm grateful that they're going up, but they're often going up for families that are white, that have higher education levels and higher income levels. In New Mexico, that remains true. So many of our Indigenous and Black and people of color communities, we were the ones most recently birthing at home and are farther from this resource now as it's become a more privileged model to access. So certainly I've appreciated that midwives helped me be in a space to become a parent, and I've worked to learn more about this model so that we can talk about making sure New Mexicans that really need it have access to this care.
Thank you so much. Now I'd really like to see if we can get into the nitty-gritties of how you work together, how you collaborate, and some of the successes that you've had, perhaps the secret sauce behind your successful collaboration. New Mexico has set its federal poverty level limit for pregnancy-related Medicaid coverage at 250% of the national level, and is also a national leader in the percent of midwife-attended births. Could you describe your collaborative efforts? How do you work with each other as advocates and providers, but also how do you work with state Medicaid agencies and managed care organizations to develop strategy and foster engagement to achieve your goals? So perhaps, give us some concrete examples of achievements and tactics that you used. So Representative Kadena, if you could focus on state Medicaid agencies.
Certainly. I'd start with saying that access to healthcare should not be a partisan issue, as too often it is. I am proud that when had opportunity, Republican governor at the time did so. And over years, our state has realized the incredible early intervention that's available by funding pregnancy-related Medicaid at a higher level. So by making that commitment, making sure we have the dollars, of course, we pull down our federal match dollars for pregnancy, it means that we can hopefully catch families when they need it and build foundations of support that are going to carry on for a long time. What's real, we're proud of the investments we make in pregnancy-related Medicaid. I like to say out loud, here in New Mexico, we trust people to make their own decisions for their bodies and lives. If someone has this eligibility, they have access to a full range of care, whether they decide to terminate a pregnancy or decide to carry a pregnancy and have access to these incredible midwives that we're working to grow across our state. One thing that's real for us that we have to face and work to navigate every day is pretty often, most years and in recent years, New Mexico has the highest level of births to pregnant people and mamas that are Medicaid eligible. That says a lot about where our starting point is, and that says that if we can get some things right in resourcing families and bringing families closer to respectful and dignified care early on, then there can be different ways that supports families and hopefully builds, like I've said, different foundation people to move through poverty, to potentially navigate poverty, and hopefully find different kinds of stability.
Thank you. I see that you've just switched to mute, so I'm assuming you're finished with that response. So Jessica, let's move to you next. If you could focus on managed care organizations and, really give us some. People on this call want to know, how did you do it? How did you achieve the success that you've seen? And we've talked about a few of the statistics that are so superlative for New Mexico. How'd you get it done?
I mean, I think it's an ongoing process. So as much as I feel like we are in a sense of accomplishment around existing, and particularly, training and employing Indigenous and Chicana midwives from New Mexico, we are definitely still in a process of learning, particularly in our collaboration with MCOs. We do, through the Birthing Options Plan of New Mexico, have a legislative pathway to access where they're required to contract with out-of-hospital birth practices, so home birth and birth center practices by law in New Mexico if they're a Medicaid MCO. And so that is significantly supportive to us, although we do find that the navigation aspect of the communication with MCOs is always very individualized. Our partnership with Bold Futures has really allowed us to take a multi-pronged approach. So we tend to always be addressing this from a legislative, regulatory, and direct contact with MCOs approach. A lot of what we do with Bold Futures is kind of have an ear into legislative and regulatory conversations that are impacting the conversations that we're having directly with our contracting MCOs. That's work that we could not possibly do all by ourselves as a tiny little rural nonprofit. And so that collaboration is really essential. The legislative pathway has been, of course, the starting place of the conversation, but I think it also has been really important to activate some of the structures like the Office of Community Health, which are the places, at least within the landscape of healthcare in New Mexico, where MCOs have some discretionary funds that they can spend on innovative programs. They haven't been quite as quick with giving up those funds as we might want them to, but those are definitely the places that we've relied on in terms of conversations around this innovative model, sharing our outcomes, and helping folks understand that we really are doing the on-the-ground work trying to address health disparities for impacted communities in New Mexico.
Mm-hmm. Thank you. And Denisia, if you could follow up and give us your thoughts on collaboration with providers and other organizations.
Sure. And what I want to say first, and I think we've all been hinting at or saying explicitly, like we have been able to move mountains in New Mexico. We're proud of that work. We're proud that we have been able to be the state with the highest number of midwife attended birth between CNMs and LMs. But there's still a lot of work to do. Our midwifery workforce is primarily white folks from out of state. Breath My Heart, incredible practitioner Belen Marcus is actually the first Indigenous woman from one of New Mexico's Indigenous communities to become licensed in the state of New Mexico since the modern licensure process. So there is incredible hurdles in the way to both communities of color and practitioners of color being in this field. Bold Futures, we are a reproductive justice organization, but see that work very broad. So we do work in criminal justice reform. We do work in maintaining and growing access to abortion and contraception, and work in birth justice. So like Jessica was mentioning, we do have greater availability to keep our pulse on the legislative and administrative change. So we are one of New Mexico's only organizations, for example, to have women of color full-time staffing the legislative session, which is a game changer for us and some of the organizations that we collaborate with. Mm-hmm. So in doing that, like I spoke to our collaboration on some of these midwifery bills, the midwives and birth workers and organizations that we collaborated with on those bills, that meant they didn't have to be at the roundhouse every single day waiting to have their bill heard. We could keep our pulse on that. We could call them, prep them, write the talking points to make sure folks were ready to share and show their expertise. There are no midwives in our New Mexico legislature of any type, CNMs or LMs. And so having their expertise there has been a game changer. I remember when we did our first hearing on allowing midwives to carry a limited formulary, it was a bill that previously hadn't gotten past one committee. And we showed up with midwives and mamas and babies, and representatives started crying, thinking about their own birth experiences. So when we're really able to shift that policy landscape and keep it from just being, traditional lobbyists, traditional communities, that really helps shift the policy needle.
Mm-hmm, mm-hmm. I can just imagine that our attendees for this session are all saying, why can't we also have a Bold Futures in our state to help us, manage all of the legislative agenda and be our eyes and ears in this very important forum? Thank you so much. We have about a minute or so left, but I would like to get your thoughts and ideas if you wouldn't mind. IMI launched the Leveraging Midwifery-Led Care to Address Disparities and Equity in Medicaid way back in October of 2020, seems like forever ago. And this is our last session. And Jennifer began today's session with what could be considered a summary of what we've all learned regarding the complexities and key stakeholders that must be considered to successfully navigate a midwifery-led model endeavor. Could you provide your reaction to the roadmap and perhaps add any advice for other states looking to establish collaborative efforts with providers, state Medicaid agencies, and Medicaid managed care organizations? So Denisia, a couple of seconds for you, and then we'll move on to Representative Kadena and Jessica.
Sure, I'm happy to jump in. I think the roadmap provides a great starting point, and I know folks on this call will be at different points in your career and path in this journey. I would say what has always worked for us is looking towards the big picture, but taking off manageable chunks, so we knew, we don't necessarily do our legislative, admin, and community strategies all at once. We look to see what can we accomplish right now, what's our low-hanging fruit, what's going to impact the most people in our communities. Our partnership with Breath of My Heart was just so natural because we knew they were serving the communities that we wanted to be looking at. Over 80% of our families in New Mexico access their birth through Medicaid, but there's very few birth centers in New Mexico. And for others, that number has been around 20%, whereas Breath of My Heart is looking at 80 to 90% of their clients as a Medicaid base. And I remember when we were working on the freestanding birth center licensure bill, we had difficulties in that conversation because at times other folks were focused on their business model when we were thinking about outcomes for women and people of color. So one of the best things that you can do is say, who is really aligned with my values, and that's who I'm going to go into this work with. Because if you don't have that as a base, it's just going to make everything else so much more difficult.
Thank you, Denisia. Representative Kadena, Jessica, do you have thoughts that you'd like to add? Just briefly.
Since Jess isn't unmuting yet, I'll say something that I've learned working with Jess over many years, both as a midwife and as a director of a nonprofit. We have to pay attention where there's scarcity and high needs. And all sorts of people pull together all sorts of possibilities when they have something that otherwise they can't address. So in a state like ours with tiny population, high levels of poverty, and of lots of rural and frontier communities, we work with midwives because we believe and trust in the model, but other folks have started to realize that if there's not birthing numbers to sustain an L&D unit in rural New Mexico, there might be a midwife that can safely catch those babies and then work through an integrated care system to get people higher levels of care when they need it. So I love what Denisia said, find people that have your aligned values, and then find these moments where there's a pocket of need, and midwives usually already are carrying the weight to fill those gaps, but help leverage that so that we can pull funding and coordination to keep building these models.
Great advice. Great advice. Jessica?
I think from the community clinic standpoint, there is really this essential part around community relationships. And so a lot of healthcare is sort of parceled off into its own organizational structures or mega structures. And for us, I think it really has been important for our work to be very deeply embedded in the community with what the community wants. That essentially you're not going to understand the full landscape of needs and thus the full landscape of strategy that needs to be embarked on until you have that depth of relationship. So just erecting, a birth center in a low-income community because that's gonna, meet a certain specific need is likely not going to have the nuance and the depth of relationship that's needed in order to do the work and the level of complexity that it truly has, because really it is very complex work.
Oh, so important, building those relationships, going where the work is so needed. And thank you so much to our panelists for this very informative discussion. I'm sure our attendees would like to hear even more from each of you. My colleague, Tricia McGinnis, has been monitoring the Q&A box during the session and has consolidated questions for our panelists. So Tricia, would you like to share the first question?
Sure. Thank you all. So the first question really goes to all of you, and that's around the impacts of COVID. Really curious to hear, undoubtedly COVID has impacted your work, but particularly interested to hear, what changes and pivots did you have to make as a result of COVID that you intend to carry forward, that you really think help promote the model, particularly for communities of color and Indigenous communities. So just throw that open to all of you, and whoever wants to jump in, go for it.
Yes, we're looking at you.
Yeah, I can speak a little bit to the on-the-ground impacts of COVID. I mean, COVID has deeply impacted our community, and I don't in any way want to kind of frame this last, year plus as having had positive impacts, because I think that ultimately it has increased vulnerability really significantly. I think for us, our pivots around COVID in the clinical setting were pretty logical. We have an open access free clinic that we run every week, and that's something that we saw a significant increase around primary care need that we were able to respond to. Our healthcare system, because we're located very rurally, is very consolidated within a hospital structure. So a lot of people access primary care through clinics that are in the same building as the hospital. The hospital was on lockdown for 11 or 12 months. And so there was a lot of services that people couldn't get that they were able to access through our walk-in clinic, because we were able to, pivot and keep it open and put COVID protocols in place. I'll defer to you all to talk a little bit more about the work of Bold Futures, but we certainly were collaborating on, the state level inputs that were needed in order to really speak the needs of our community during that time, because we did see the whole healthcare system really just totally turn away from pregnant parenting families, from, infants and children in terms of those needs. Obviously, there was a logical priority given to, older folks, but there was also just kind of an abandonment of any kind of perspective around the needs of pregnant and parenting people during the pandemic. So I'll pass it to you, Denisia.
Yeah, great. Thanks, Jessica. And yes, we were working with Breath of My Heart in this critically impactful time. And definitely, just like the disparities in midwifery exist in our state, the disparities around COVID were fueled and devastating in our state. We had high numbers of elders being lost in Indigenous communities and Chicano communities, and it was greatly impactful. Like Jessica said, there was a need in New Mexico and nationwide to address elders in COVID and the whole landscape, but we did not see what we felt was a needed focus on pregnant people, pregnancy, and birth care. So we started to have those conversations, and we reached out to some of our partners at Black, Indigenous, and people of color organizations and those leaders, and we had started those conversations. Soon after that, there was an investigative journalism piece, an incredible piece of work published on how one of our local hospitals, Loveless Women's, had actually created a policy of people they assumed of separating mothers and parents and people they assumed to be Native American based on their perception of them and zip code from their newborns. That was, of course, not CDC guidance. It was not WHO guidance. It was not medically necessary and incredibly traumatic. So after that, the need to put forth some work became even more urgent. And that group of incredible collaborators that included like I said, Black, Indigenous, and people of color providers, advocates, and leaders put together a set of emergency recommendations to consider in COVID and beyond. And I'm going to pop that in the chat because I do think it is a really important document that should be considered by systems, hospital systems, birthing centers, providers of all kinds. And we were really proud to put forth that document and have conversations with state agencies thereafter. And Michaela, I was wondering if you wanted to share a little bit about the work you did with Breath of My Heart around shifting billing and coding practices to support work in COVID.
Just quickly, I would say the relationships that mattered before a global pandemic certainly mattered as we work to navigate situations like this. I remember in the first couple of months, New Mexico, like so many, were celebrating that we could move some Medicaid codes to telemedicine and have reimbursement. But because midwives are too often an afterthought in gigantic healthcare systems, I think Jess and I, maybe Denisia, jumped on a phone within a couple of days with the Medicaid director to make sure that some of the new provisions that came with Medicaid payment for telemedicine and other functions also included midwives and the CPM billing codes we have in our state. So it's just always that, like, unfortunately, we have to continue to center and clarify that the same kind of provisions that are being made for providers across healthcare systems also have attention here. I would just say that one of the big learning moments for me as a state policymaker is that I spent the first couple of moments in really frustrating conversations with my friends that are cabinet secretaries running agencies like HSD in our state, asking about plans for taking care of pregnant people that potentially, and our governor's a champion, abortion was never threatened in our state. We know that's essential health care, but really it was disheartening to know that among all the conversations happening, nobody was going to talk about how pregnant people were going to show up in hospitals and still need care no matter how many empty beds we had or didn't have. So for us as advocates and policymakers, in the long run, we are definitely laying down the foundation to make sure that we have plans like this established, that they include integrated models of care, and that we have a place to start a conversation should a hospital be at capacity or shut down in the future, to make sure that pregnant people, we know they're the highest number of people that show up in hospitals for care, and they're not sick. And in our state, like so many, we didn't have a plan to compensate for what they might need. In the future, we're gonna make sure we have something in place.
Great, thank you all for reflecting on that. We have time for one more question that again I'll put out to all of you, and that is just what were the pivotal 2 or 3 things that New Mexico did that allowed for the wider use of midwifery in the state, looking at Medicaid policy? Were these delivery system reform changes, payment changes, contracting changes? From a Medicaid policy perspective, what were the 2 or 3 policy changes that, in your view, have had the most impact in really laying the foundation for advancing midwifery models?
Well, from my understanding, New Mexico has provided Medicaid coverage for out-of-hospital birth and midwifery models significantly over time. There was a period, I believe between 1999 and 2005, where it was not provided for. So 2005 was the last time that there was legislative action around midwifery care provision under Medicaid in New Mexico. And so certainly, like, the work of those folks laying that groundwork around, particularly the Birthing Options Program provides an exemption for licensed midwives so that they basically don't need to carry malpractice insurance in order to be covered by Medicaid. And I would say that's a very significant provision, especially for dispersed providers. I mean, the calculation is that standard malpractice programs would cost between 20 to 30% of folks' annual income in order to carry, so it would be entirely prohibitive to practice. So I would say that that's a very significant piece in the New Mexico landscape, is that exception from malpractice coverage to become a Medicaid provider.
Denisia or Representative Kadena, would you all add anything else to round out Jessica's list?
No, what Jessica mentioned is critical. For me, one of the biggest is extending our Medicaid eligibility to the 250%. That means more people can get served. The people between 185 and 250% don't have money to be seeking different models of care, the care that might best serve their needs. And just want to emphasize again to the audience, like, we are so proud of the accomplishments we've made, and there's so much further to go.
Mhm.
And my last note would be to say that we've certainly based all these conversations in looking at the disparities in outcomes that too many of our families are facing in New Mexico. That's Indigenous birthing people and Black birthing people. The models that blow up everywhere and most families access have not made anything better. So we're at a pivotal point where we can make grounding decisions that turn families closer to care, that potentially make it that families have something that's going to work for where they are. I'd say the little caveat with that is that there's other midwives and folks that sometimes say, come to us, we're cheaper. We don't want to undervalue that midwives deserve to be paid and paid equitably. But yeah, it's a model of care that's affordable and can certainly get to much better outcomes for families that otherwise have seen discrimination in healthcare systems. So more than ever, those are conversations we should be having in our maternal mortality review committees and other spaces, like looking at the research to show where outcomes have potential to get better. Thank you. I just wanted to name, Denisia put the report she mentioned in the chat, both the COVID recommendations for New Mexico and the ProPublica piece about the really horrific story about separating babies from their parents during COVID. So thank you all for that.
And I just wanted to share super quickly, because lineage is really important to us. Like, Bold Futures and Breath of My Heart have both been deeply informed by the work of Mama Toto in DC, by other Black women and midwives, by Indigenous women across the country who are really reshaping Medicaid models and private payer to better serve the needs of midwives and the people they serve.
Great. Well, thank you to our panelists for their thoughtful, informative answers and this really engaging discussion. This has been an amazing panel to have to wrap up this 8-part series, and want to thank each of you for participating. At the beginning of today's session, we offered a roadmap with an interactive checklist to support your efforts. You then heard from individuals from New Mexico as they shared their successes and, as they mentioned, ongoing journey towards advancing midwifery-led models of care in their state. We now have one more action step as part of today's session. 2 weeks ago, the Aspen Health Strategy Group, led by former HHS Secretaries Kathleen Sebelius and Tommy Thompson, along with CEOs from the nation's biggest healthcare industries, released a report on maternal mortality in the US. In the report, they noted the following: the medical model of birth does not meet women's needs. Racism and racist policies are at the root of the maternal mortality crisis. Payment and regulatory structures overemphasize the medical model, and high rates of maternal mortality reflect our limited investment in women's health. The report also identified 5 big ideas that they are calling upon all of us as a nation to take action. Building and supporting community care models, specifically midwifery-led models of care and doulas, was noted as a top priority and action item. Aligning payment around access and coverage to these community-based models was also emphasized, along with acknowledging that our current maternal health system has been negatively influenced by racism and social, gender, and economic oppression. The report notes that the time for action is now, but each of us knows that change isn't easy. So where do we begin? Who do we call when we get stuck? As we noted during each state technical assistant call earlier this year, IMI is preparing to launch a multi-year national learning collaborative that will offer intensive and individualized support and assistance for state-based teams to advance midwifery-led models of care. The IMI team is assembling a group of experts who will work closely with each state-based team to support your goals and your framework. The overall objectives of the Learning Collaborative will be to engage Medicaid agencies, Medicaid health plans, midwifery-led provider groups, and community consumer groups to support their interest in designing and piloting a midwifery-led model of care and Medicaid initiative. To expand dissemination and support a deeper dive into the key topics and resources from this learning series and reports. To increase the uptake of key concepts that are critical for advancing midwifery-led care for the Medicaid population. To provide technical support and learning opportunities for Medicaid stakeholders to explore next steps for implementation. To provide assistance to Medicaid stakeholders to engage with each other in their partnership. And finally, to leverage the curriculum's value and the industry expertise of the stakeholders. At this time, everyone in this learning series who participated in their state technical assistant call has received detailed information about the opportunity, including how to apply. The information is also available on the IMI website and is being placed in the chat box now. To briefly highlight a few facts, we will be selecting up to 5 state-based teams to work closely with the IMI team and expert consultants to support your journey. Each state-based team must have a representation from the state Medicaid agency, Medicaid health plan, provider group, and consumer community group. The focus will be on collaboration and co-creation, the identification and reduction of barriers, and the implementation of a pilot initiative. And the best part is there is no cost to participate. And actually, we will be providing a small honorarium each year to each state-based team to support your participation. As noted in the materials about the Learning Collaborative, we will be hosting a TA webinar about the application process and to provide an opportunity for you to ask questions on June 10th from 3 to 4 p.m. Eastern Time. And finally, before I hand it off to Lydia to close out today's session, our final session, on behalf of the entire IMI team, our colleagues at CHCS, and each of the speakers and panelists who have joined us during this 8-part learning series, we want to thank you for your participation in this opportunity. It has been a sincere joy and true pleasure to learn alongside with you. We look forward to your participation in the upcoming Learning Collaborative. And now I'll hand it off to Lydia, who will go over a few wrap-up items before we close today's session.
Thank you. At this time, everyone should have received an email with the link to complete today's brief 5-minute session evaluation. If you did not receive the email with the session evaluation, please contact me. My email is listed on the slide. We will be sending the presentation slides and archived recording of today's session by email to you within the next 2 weeks. We will also email with more information about the upcoming Learning Collaborative, including links to access the fact sheet, overview document, and the application. Dr. Moore will also reach out to those who participated in each of the state check-in calls with additional information about the Learning Collaborative. Thank you again for your participation in this learning series. We look forward to your participation in the upcoming Learning Collaborative. Thank you.